Today we're going to be talking about cutting-edge regenerative medicine for pain patients with Dr. Casey Seenauth. Give us just a minute and we'll be started in a second. Thank you so much for coming. Okay, Dr. Seenauth, we're not able to hear you. Are you there?
Hello.
Ah, there you are. Fabulous.
Okay, I'm here.
Okay, fabulous. Thank you so much. Sorry about the slight delay, folks. So I will introduce our speaker and we will start on the process. Dr. Seenauth, when you're ready to advance the slides, just let us know. So
Okay.
Welcome today to Cutting Edge Regenerative Medicine for Pain Patients. Today we have with us Dr. Casey Seenauth. And Dr. Seenauth is a graduate, 2013 graduate of the Southwest College of Naturopathic Medicine and licensed ND in Arizona. He has a passion for treating acute and chronic pain, sports injuries, and musculoskeletal conditions. And we are so happy to have him with us today. He has a special interest in regenerative injection therapies and prolotherapy, but has a fully comprehensive ND practice that utilizes all of the tools in our toolbox. So before we turn over the screen and the presentation to Dr. Seenauth, we just want to remind folks, if you have questions for us, there is a Q&A box. So if you look at the bottom of your webinar Zoom platform, there's a Q&A box. Please put all questions in there for us and we'll respond to them as best we can. And the webinar will also be recorded. So if you missed something and you want to go back, we'll have that recording for you. So I'm going to make my face go away and turn over the stage to Dr. Seenauth. Thank you so much for joining us today.
All right. Well, everybody, welcome. So yeah, the topic today is going to be about cutting-edge regenerative medicine for pain patients. I'll talk to you a little bit about how I've implemented regenerative medicine into my practice, some of the theories about how regenerative medicine fits into naturopathic philosophy, how I got into it, and share a couple of cases with you. So yeah, let's get right into it. Next slide, please. All right, so a little bit of a quick history on me. So did my undergrad in Florida, Fort Lauderdale Atlantic University, graduated in 2007. So go Owls for any of you FAU fans or alum out there. I did my naturopathic training at Southwest College of Naturopathic Medicine, graduated in 2013. And during that time, I had a very broad range of interests. I did a lot of homeopathy, a lot of botanical medicine. And it was towards the end of my training, probably my fourth year, that I started really having an appreciation for physical medicine and addressing how the body's structure dictates function and how we could make a lot of impact for people who are suffering from pain conditions. It's around that time that I started got an introduction to some of the regenerative medicine stuff that we're going to talk about today. After I completed my degree at SCNM, I got into a residency program, and I did 2 years of general medicine, family medicine residency at SCNM. And during my second year of residency there, I had the opportunity to work with an integrative pain medicine doctor, who I'll talk a little bit more about later, and basically got a lot of experience observing injection therapy, interventional pain medicine, and looking at what was a conventional medicine approach to treating pain, and started to kind of synthesize that information of the experience I had as a naturopathic student of how these things may be similar in some ways, different in others, and how they complement each other. So after I completed my residency, SCNM expanded our clinics to create a new clinic to focus on treating folks with chronic pain, and that's a place now called the Neil Riordan Center, where I've been practicing since 2016. At our clinic here, we focus on the full range of naturopathic medicine modalities, looking at how to create comprehensive, integrative, multimodality treatment plans to help folks in pain, and focusing on less invasive, non-opioid, non-pharmacological interventions where possible, and that's where I've been practicing since residency. During my time as a student, got involved with some extracurricular activities as well. At SCNM, we have a very robust range of programs to get involved in. I was did a bunch of time with Naturopaths Without Borders, which is a group that does kind of medical mission trips to various underserved communities around the world. When I was a student, NWB was still pretty new. So we were working on becoming a not-for-profit organization. At that time, we basically would just pack up the cars on a weekend, drive down into Mexico, and go to different towns that were really lacking in medical care, and we were able to provide some basic care for those patients. And I'm glad to say that as the organization has grown and they've gotten more and more resources, we've actually been bringing some of the therapies that I'm going to talk about today. We've been able to apply them for patients over there. So just because regenerative medicine sounds high-tech and fancy doesn't mean it needs to be expensive or difficult to access. So that's something we'll talk about a little bit later. I was also involved with ENACT, which is a group that works to expand access to naturopathic medicine for people who maybe don't have it. We work with the AANMC with initiatives like DC Fly, heading to Washington, spreading the message with our legislators to try to increase the availability of this medicine to people all over the country. So that's a little bit about my history. Next slide, please.
So Dr. Seenauth, before we go into the next slide, I just want to see where our audience is from. So we're going to put up a really quick poll. If you would not mind answering where you're joining us from and which of the following best describes who you are, so we know who's on the call today, and we can put up the results from that poll really quickly. The other thing while folks are answering that poll is that next month we have a webinar with the founder of Naturopaths Without Borders, Dr. Sean Hessler, talking about using naturopathic medicine across the globe. So it's really timely that you brought up your work with NWB, because we're going to have Dr. Sean on with us next month. So awesome. So we'll have that poll up. So Dr. Seenauth, if you want to keep going, sorry to interrupt you there. Thanks.
Oh, no worries. Yeah. Excellent. All right. So a little bit more, I talked about briefly how I got into regenerative medicine, or the steps that got me there. So personal experience, when I was starting my second year of naturopathic medical school, I sprained my ankle really badly. I had a grade 2, maybe the edge of a grade 3 sprain. Had to be off of it for 2 weeks, used crutches to get around class. It was miserable. But once the acute phase of the swelling came down, I went in and got some, I came into a student clinic. They did a range of therapies with me, including some prolotherapy injections. And that really sped along my recovery and got me back into performing shape, I suppose. I later on had another experience where I got to use some PRP injections to it, and that got me from feeling unstable to able to run a Ragnar trail event that fall. In about a 6-week period, I went from not knowing if I'd be able to complete it to steady. So personally, I've used regenerative medicine myself. on me and my family. But during my training at SCNM, during my residency, I worked with faculty here like Nick Baratovich, Dan Inouye, both doctors who worked with, who've been learned regenerative medicine prolotherapy from a group called NATI, the Naturopathic Association of Therapeutic Injections, under the leadership of Rick Marinelli, who kind of really brought prolotherapy to the naturopathic community. So a couple of those guys are on faculty at SCNM. I learned from them as a student. And then again, I mentioned here at the Neil Riordan Center for Regenerative Medicine, that interventional pain doctor, Dr. Clee Bethel. He's actually a medical doctor who's on staff here. He's the senior staff physician that leads our clinic. He brings over 25 years of injection or interventional pain management experience to the clinic. So he's extremely experienced and well-versed in using therapies like epidural injections, nerve blocks, facet joint injections. And because he's a part of our clinic, we have a training opportunity for residents and fourth-year students who are really into this type of medicine to get training that's not really available in many other places in the naturopathic world. Because fortunately, a lot of the techniques that you use in regenerative injection therapies are almost the same physical techniques that you would use if you were doing steroid injections or nerve blocks or other interventional pain techniques. It's about applying the right medicine to the right location through a needle. You have to know the anatomy. You have to understand imaging techniques, the approaches. So we're really fortunate that for the last several years, I've been working with Dr. Bethel, and he's been helping me refine my techniques and approaches there. So that's some more background on regenerative medicine for me. Next slide, please. Okay, so regenerative medicine sounds like it's high tech, sounds like it might be a little invasive. I mean, we're applying a medicine through a needle for many of these techniques. So how does that fit in a therapeutic order? How does a naturopath know when to apply this? So this slide here is a diagram of the naturopathic therapeutic order, and this guides the approach that naturopaths take to how to decide what treatment to do for which patient and when. And generally, you start at the bottom of this pyramid and you work from these least invasive approaches to more invasive approaches going up. And as you progress up this order, you're looking at therapies that work from the inside to stimulate healing and establishing that the patient has everything they need to be as healthy as possible. And then you go up, you start removing things that might be obstacles. You might be optimizing different physiological processes. And generally, the interventions become a little more invasive as you go up. And you'll see stuff like surgery or drugs at the top. And, it's not always a strict hierarchy or strict progression, start at the bottom and go up. Each patient you have to individualize. But overall, if you follow this and you generally restore health for the patient and treat the disease by doing that. So this is the framework, the conceptual framework for how a naturopath thinks. But where does regenerative medicine fit in there? So in my time working here at SCNM and with some of the other great minds here, I've kind of come up with a variation on the therapeutic order that I think helps to inform my clinical practice, and I'll show it to you on the next slide. So next slide, please. All right, so this, I worked with Dr. Paul Mittman, the president and CEO at SCNM here. We've kind of brainstormed this diagram because it takes what we know about the therapeutic order and just reimagines the flow of it a little bit to kind of really focus on that individualization for the therapy. And I added a factor here. Right in the center of this circle is the diagnosis. So when it's super important as naturopaths, oftentimes we look at this as a separate paradigm in the way that naturopaths think, that we're not necessarily treating a patient's disease like we do in the conventional model, but we are working with the patient to restore health. So sometimes the specific disease entity, the diagnosis is not is de-emphasized. But when you're using interventions, the diagnosis is critical because it informs how you're going to monitor the patient's progress, how you're going to gauge their response, what you know about their prognosis, what's the time frame for how this condition typically progresses. All that information is stuff that is enlightened by understanding the diagnosis. So we put that right in the center here. And then we take some familiar concepts that we see in the other therapeutic order slides, starting up here on the red, the therapeutic life changes. That's where we're looking at how do we address the foundations of health. You know, how do we remove obstacles, deal with stuff like someone having a poor diet or someone sleeping poorly or having unmanaged stress. These are all factors that are going to make them feel less well. And then we move on to, you know, supporting, promoting that healing power of nature, the vis medicatrix naturae, so to speak. A lot of therapies that we use directly address this, things like homeopathy that stimulate to repair the attunement to the vital force, or acupuncture, which works on the chi and opening the meridian. We also have regenerative medicine. I think it fits in right here because regenerative medicine, despite it sounding a lot more high-tech than using homeopathy, for example, it does directly stimulate your body's ability to maintain, heal, and restore tissue. So I think it operates on that level. Then going around, we look at supporting organ systems or structure. So naturopaths, often a big example of that would be like GI health, looking at how, you know, assimilation of food and nutrition affects our ability to heal and our ability to perform. So looking at optimizing that GI gut function is something that comes up very frequently, and we do that with a variety of tools, with nutrition, with botanical medicine, diet, all that. And then we start getting into, on the left side of the circle, some of the things that may be considered more invasive or more higher up on the therapeutic order pyramid, looking at structural integrity. That would be things like joint manipulation, soft tissue massage therapy, stuff like that. And then the last two, addressing pathology or removing pathology through drugs or surgery. You know, we can often even use natural substances to address pathology. There are a lot of plant medicines that can work in sort of a suppressive way to suppress symptoms if you need to, and something's really severe. But the important thing about this being a circle is that patients come and go at different points in this continuum. You know, if a patient comes in and they've got a tendon that's completely ruptured, a complete torn Achilles tendon, you know, as much as I might want to provide nutrition to give building blocks for connective tissue repair and use hydrotherapy to reduce inflammation, maybe use botanical extracts to bring down the pain, if the ends of that tendon are not mechanically approximated through surgery, that tendon's not going to repair. So the diagnosis and looking at the individual case informs where we go on this therapeutic order. Okay, next slide. Okay, I'll share a couple of cases with you. And these are three cases that kind of illustrate a range of regenerative injection therapy modalities that I use in my practice frequently, and different types of cases, different people that might come in, and how I kind of decided which therapy to use in which case. So the three approaches are going to be perineural injection therapy, prolotherapy, and I'll talk a little bit about a stem cell treatment that I did recently. All right, so next slide. All right, so the first case, this is a perineural injection therapy case, and the patient is a 35-year-old male. He was lying in bed one night with his partner, and he rolled over and bumped his arm just behind his elbow against his partner's head. Didn't think much of it, but went to sleep. The next morning, he woke up with a kind of a deep ache that he felt in the back of his arm and up to the deltoid on that right side. He reported it being 8 out of 10. This pain persisted for about a month. It would kind of wax him in a little bit, but stayed pretty significant. He tried using ice. He tried rolling the muscle out with a lacrosse ball, doing some rolling himself, and that helped a little bit, but it always seemed to come right back within a few minutes. It was kind of that, like, it hurts really good when he was working on it, but the dull, throbby kind of ache never really went away. Lying in bed on the affected side made it worse. Stretching his arm overhead made it worse. Pushing movements were worse. And this gentleman worked as a hairstylist, so a lot of overhead work with his hands, reaching up, reaching out, and it really was starting to affect his work day to day. So he came in, we examined him, and we found that he had tenderness to palpation over the medial and posterior deltoid. He had pain when he tried to flex his arm, abducting his arm, bringing it out. Also, turning his neck towards that side caused pain to radiate, from the shoulder, and actually some radiation from the mid back up to his shoulder. Next slide. So in this case, we saw these radiating pain patterns. He had some weakness, like grade 4 out of 5, not actual frank weakness, but just a little bit less than the other side. And it indicated to me that based on the type of injury he had, it wasn't a significant trauma. He just bumped his arm. He not likely tore anything or had any significant sprains. It wasn't like the type of insidious long-term onset as like an arthritis would be. So it sounded like there was nerve involvement. So what we did is we looked at what do we have treatment-wise that we can deal with nerve inflammation. This nerve was definitely, he hit it, and this nerve was not calming down the way that it should. So we have this technique called perineural injection therapy, where we use low concentrations of dextrose, basically sugar, a very low concentration, about 5%, and inject it along nerve endings. The nerves take up this solution, and they kind of reduce inflammation. So these nerves, when they're inflamed and irritated, they put out inflammatory signals into the tissue around them, and that can cause the muscles or even the joints that they're supplying to become painful and start to lose some function. So in this case, we found a branch of the axillary nerve, which comes out right at the back of the shoulder. In the diagram there, the quadrangular space is where that nerve exists. We injected about 6 cc's or 6 milliliters of this dextrose solution around that nerve and around its branches. And at the end of that visit, the patient got up off the table. We had him repeat those movements that were painful, and within a 5-minute span of time, he was able to completely abduct his shoulder without pain, which is that movement that was painful immediately before the treatment. And this 8 out of 10 pain just completely resolved. So in this case, the entire pattern of pain was just due to a sensory nerve inflammation, and we were able to address it with an injection of basically of low concentration sugar water. Very accessible, very inexpensive. This is one of those modalities that NWB and the students brought down to one of their clinics in Mexico to help folks with chronic pain. And the cost of supplies is minimal for this type of intervention. It's not super invasive because we're going for nerve endings. You can get this done with a very short needle injection just below the skin in the subcutaneous space. So it's not invasive at all. Okay, so that's perineural. Next slide, we'll talk about prolotherapy. Okay, so this case, another male in his mid-30s had pain for 2 years, and this pain, he had the pain started when he was playing basketball. He went up for a layup, and he got fouled, and he went down, landed on his right shoulder, and reported intense 10 out of 10 pain initially, and couldn't really raise his arm more than 20 or 30 degrees of flexion or abduction. Had difficulty lying on the affected side at night to sleep. Pain would spike up if he slept on it funny. But this young man was a firefighter, a tough guy. He didn't seek initial treatment after the injury. He thought he'd just sleep it off. And, it started to get better, but it was never pain-free. He would go through cycles of every 4 or 5 weeks. His pain would flare up from 8 out of 10, then it would go down to maybe 3 to 4 out of 10 resting. But he always had that limitation with his right arm. He couldn't get it up overhead to lift things, and it really was limiting for him his work as a firefighter. He's constantly lifting, moving heavy things. So he was just kind of living with it. And about 2 years post-injury, he decided to come in and get this addressed. So he came into the clinic, and we evaluated him and revealed he had crunching sensations in the joint, kind of a lot of crepitus. And, we did our exam, and due to observing his pain with his abducting the arm and some of the orthopedic testing we did, we were able to kind of narrow this down to a supraspinatus tendinopathy or shoulder impingement syndrome. The supraspinatus tendon was injured when he went from that fall. So we decided to go with prolotherapy to treat this. So next slide, please. Okay, so this is a case that actually I worked on during my residency, and I've got it. It's the case report is published, and so you guys can find this on PubMed and follow along with the case or read it later on if you want to get into it. But basically, we did dextrose prolotherapy. So this is a treatment that uses high concentration dextrose and some local anesthetic. You don't necessarily need the local, but it's mostly the dextrose that does the action. And it addresses soft tissue instability. So when you inject high concentration dextrose into a ligament, a couple of things happen. You have a response where that hyperosmolar solution kind of dries the tissue out a little bit, and that in the case of a ligament where you have those ligament fibers, it can tighten the ligament fibers and cause increased instability in the joint. You also have a chemical effect where the dextrose, when those cells dry, some of those cells in the area will lyse and then release inflammatory cytokines into the tissue, which then stimulates a healing response. So if you look at a chronic injury like this guy's shoulder pain for 2 years, you have this wound healing cascade that happens up front where you go through this inflammatory phase for a couple of days, and then you have a proliferation phase that might last 2 to 6, maybe 8 weeks, and then that tissue remodels and becomes strong and normal tissue over a long period of time. If you don't get enough proliferation in that first phase, you're going to have incomplete healing. With Prolo, what we can do is kind of encourage the body to start a new inflammatory cascade, which will jumpstart a new healing cascade long after the injury. So for chronic stuff like this, it's a very good option. Lots of people have chronic injuries, old sports injuries, stuff like that. Works great. I also use this commonly in things like ankle sprains, where you have lots of ligament involvement, and perhaps being extremity, maybe don't have the best blood supply, or because you walk on it a lot, don't get a lot of rest to it, so those injuries are slow to heal. Prolotherapy often encourages those to heal more rapidly and more completely. So for this patient, it took several treatments, but we did get him to be pain-free, 4 treatments over the course of 3 months, I believe. And he would come in, we'd get the injection, he'd have a little bit of a flare-up afterwards, where his pain might spike for about 2 days. Maybe go up 2 or 3 points on the scale, and that was significant because of the activation of the tissue from the injection, and then after that we have slow gradual healing. These diagrams, these photos down here are just photos of me doing a shoulder treatment on a patient, demonstrating some of the locations that we inject for the posterior shoulder capsule, the supraspace, and the acromioclavicular joint here. Okay, next slide. Okay. This is my third case I'm going to share with you, and this is a 56-year-old female who's been having bilateral knee pain and had been progressively getting worse. This patient, she was a nurse, so she was on her feet a lot for work, and just over time, she thinks she was just wearing out her knees. No trauma to report, nothing significant, but she did go to an orthopedist about 3 years prior who saw that she had bilateral medial meniscus injuries, and opted to do repair on one of them, arthroscopic repair on the right. So interestingly, when she came to see me, the knee that wasn't operated on was the less painful. The right knee was the bad one, rated 8 out of 10. Aggravated with activity, aggravated with going up and down stairs was her worst action, thing that caused her the most pain. She also reported having, after the arthroscopy, the pain inside the joint might have been a little bit less, but she had this tight, burning, kind of pulling sensation across that joint line on the right side. And the left side says since also had this tightness in this pain. Her initial x-rays, which I threw a shot up on the screen here, is a little bit narrow on the medial compartment in either side to correspond where that meniscus injuries are. So with this long-standing history of pain, the development of arthritis, the meniscus injury, we knew that our intervention had to be a little bit more forceful, a little stronger than using prolotherapy. This patient was interested in doing some stem cell work, so we looked into that. So next slide. Okay, got some diagrams or some x-ray pictures from doing this case from the treatment. So we decided to do stem cell therapy with her, and we decided to do what we call autologous stem cells. Autologous meaning that the source of the cells and the patient receiving the cells are the same person. So here, this picture on the left is that dark line is my bone needle, which are used to access the bone marrow on the posterior side of her pelvis on the left, and extracted a few tablespoons worth of bone marrow. Bone marrow is a rich source of a lot of things, but the main one we're concerned about is stem cells, MSCs, mesenchymal stem cells. Bone marrow is one of those reservoirs in the adult body where stem cells reside, and they can be harvested and concentrated. There's also some blood that you get out from there, so concentration of this material gets you platelet-rich plasma, which is another source of healing factors. But basically, MSCs, they work, they work to signal other tissue types and kind of direct healing and repair by identifying and recognizing injury and influencing tissue to proliferate. So in her case, in this arthritis case, she has worn cartilage on the articular surface of her knee, and the stem cells can encourage that cartilage to remodel a bit. We're still kind of in the early phase of seeing what can be done with MSCs. In the big picture, there's a lot of research being done in tissue engineering. Folks are trying to rebuild organs, rebuild structures in the lab. It would be really amazing one day if we're able to come up with ways to engineer surgical implants, maybe one day like grow a new meniscus out of MSCs and then use that to repair a joint. But for now, we do know that using these in injections in a local area of an injury can influence the environment inside a joint, decrease inflammation, and encourage repair. So this picture on the right, you can see the joint space of this knee. Image is flipped upside down, so the inferior is top, superior is up the bottom of the picture. You can see this dark line in the joint space. That's my contrast medium, which I injected to confirm the needle placement inside the joint space. And then once that went in, we followed that up with this bone marrow aspirate concentrate. Okay, next slide. So this is actually a pretty recent case. So I have some early follow-up information for her. I called her 1 week post-treatment, and she was having that kind of 8 out of 10 pain intermittently before the treatment. Post-treatment, her pain had decreased. She had only had anything as severe as a 2 out of 10 during the week following treatment. So the MSCs definitely have an anti-inflammatory effect up front that the patient will note in the short term. Then we called her again at 1 month post-treatment to follow up, and the big improvement was that she still had this aching pain, and certain activities were still uncomfortable for her, but going up and down stairs, she no longer has any pain going up the stairs. Going down, still a little bit uncomfortable, a little more loading, weight bearing of that kind of impact of going down, but going up, something that was severely limiting for her before, is pain-free. And we're continuing to follow this patient's outcomes here at the Neil Riordan Center. We've been doing long-term outcome monitoring with these patients because we're hoping to be able to publish some data that on the effectiveness of the stem cell treatments for things like arthritis. So really promising outcomes, really good progress with this particular patient. It was just one example of something I might use stem cells for. Next slide. Okay, so what do I love about naturopathic medicine? How'd I get into it? Why do I love being here and doing what I do? There's a lot of reasons, and I could spend all day talking about all the various aspects of our medicine that appeal to me and that encourage me and inspire me every day. But one thing I want to talk about is creativity in our medicine. And you might have gotten a little whiff of this talking about the therapeutic order, but this is an important topic, and it's relevant today because in my emails almost every week I get newsletters from Medscape and from different physicians groups talking about physician burnout. How do you deal with physician burnout? I read a report from Harvard and Mass Health titled "A Crisis in Healthcare: A Call to Action on Physician Burnout." And they call it a public health crisis that physicians are getting burned out, which is really alarming and really a big deal. and everybody's theorizing on why is it a problem? You know, do they give doctors too much busy work? Do doctors have to spend too much time charting EHRs? Do doctors get bogged down with insurance billing? Are doctors not resilient enough? Do we not take good enough care of ourselves? Do we need, so they have solutions like, you know, we're going to streamline your workflow. We're going to develop a new EHR. We're going to provide mental health services for doctors. But I think the solution is simpler than all that. And really, one thing that contributes to burnout is when you don't have autonomy, when doctors don't have the ability to kind of make meaningful decisions for themselves about the way that they work and about the things that they do to help their patients. And that adds a lot of stress, you know, when you feel like you don't have control or you don't have freedom in what you're doing to make meaningful impact. So as a naturopath, working through the therapeutic order and deciding how to individualize the therapy and look at this patient in front of me and develop a relationship with them and get to know their story and really understand them. And you have so many options. I mean, in Arizona here where I am with my scope of practice, there's a wide range of conventional medical therapies that are in my scope to use. I mean, I could prescribe, you know, NSAIDs or muscle relaxants for my arthritis patients, just like their primary care or their orthopedist might. But I also have a wide range of other things available, like regenerative injection therapies, for example, but also I use homeopathy consistently in my practice. I use traditional Chinese medicine, and, you know, all my patients get help with their nutrition to make sure that they have the raw materials their body needs to grow and repair. So it's like a wide palette of different colors, you know, that I can use to work on this. And just talking to some of my colleagues who are in other places in the healthcare industry, they don't feel like they have that. You know, when you're looking at this conventional model of treating disease where your patient, you make a diagnosis first, and that's the most important thing about the case, it leads to this algorithm type care where, like, if the patient has disease X, then you give drug Y. And that's it. There's no room for the physician to practice the art of medicine. So as a naturopath, we're not kind of bogged down by some of that, which I think really is one of the great things about what I do, and something that keeps me really inspired. Okay, next slide. Okay, so where are we going with regenerative medicine here at SCNM? One thing that is very exciting for me is training students. I mean, I work with students every day. About half of the time I spend at work each week is training students on my clinic rotations. And we have a new program here at SCNM where we are doing an honors track. Fourth-year students who have demonstrated proficiency in all of their general medicine requirements and, you know, passed their milestone exams have the option to do additional rotations with me and the other doctors in the Neil Riordan Center to learn these techniques, learn how to get proficient in doing injections, how to make injection therapy, regenerative injection therapy, part of a comprehensive naturopathic treatment plan. And it's extra work. These students have to, they have extra classes that they do with me. We do a journal club and look at the research. We do skills workshopping outside of their classes and their assigned rotation. So it is extra work, but these students do get a certificate when they graduate that they've focused on this area. So that's really, really cool. You know, for you guys who are thinking about going into naturopathic medicine and want to figure out how to become a part of this healthcare world, I think the future of our care is going to be integrative. It's going to be about spreading our message and making connections and building relationships with everyone in the healthcare community. Because naturopathic medicine has lots to offer, and I think our model can offer a lot of solutions to this reductionist conventional approach, which thinks that, you know, there's going to be a biomechanical solution for every problem. There's going to be a chemical, a drug, a molecule that can fix pathology. Whereas we know as naturopaths that you treat the whole person, and that an individual is more than the sum of their parts. And that perspective really helps us to enable people to get back to health in ways that other approaches don't. So next slide, I want to share something about looking forward to the future. In the world of pain, this is something I read up on a lot. We know that we've had this problem with prescribing opioids, overprescribing them. People are getting addicted. People are getting dependent, and then we're having a huge problem with overdose deaths. And the solution has been just for conventional medicine to just close the tap. Just cutting off people from getting their opioid prescriptions, which is good because we're having less deaths due to prescribed opioids, but it doesn't address the root problem, which is that people are in pain. So many of the groups of conventional physicians, this one paper, the American College of Physicians published these clinical guidelines, and basically they looked at data from 2008 to 2016, and they did the systematic review and found that for chronic low back pain, the first line therapy should be non-pharmacologic, focus on things like exercise, multidisciplinary rehabilitation, mindfulness-based stress reduction, spinal manipulation, lots of things that are part of the modalities that naturopathic medicine uses all the time. I think naturopaths should be front and center in this problem of dealing with chronic pain. Other big groups in our government agree. The Department of Defense, the Department of Veterans Affairs did a study in 2017 spanning 10 years of evidence from the VA system and came to very similar conclusions. Mindfulness-based stress reduction, spinal mobilization manipulation, patient self-care options, cognitive therapy, behavioral therapy were all things that they recommended and all things that naturopaths should be out there and be providing to the patient. They also gave a strong recommendation against the use of long-term opioid therapy or benzodiazepines or corticosteroids. So steroids, benzos, opioids, all things that we don't have to use when our patients have access to regenerative medicine options. Okay, so next slide. All right, so again, if you want to contact me with questions, my email is up on the screen. I am available to answer questions about regenerative medicine or about wanting to get into naturopathic medicine. Talk to me about my experience with the program, going through the program, or being a resident or anything like that. I'll be happy to discuss that with you. Thank you.
Thank you so much, Dr. Seenauth. Jamie, if you could put the next slide up. So before we go to questions, I just want to let you all know about some of our upcoming events. So next month on October 17th, we have Naturopathic Global Health with Dr. Sean Hessler. And then the following month, we will be talking about type 2 diabetes. We will also have our Naturopathic Virtual Fair later on in November too. So if there's anything that you're interested in hearing about to become an ND student, the ND Virtual Fair is the place to do that. So with that, I'm going to send a couple questions your way, Dr. Seenauth. So first, I'm going to combine two of the questions. So you had a photo of you with some imaging equipment, and also there was a question about whether or not you use ultrasound for some of the injection therapies that you use. So can you speak a little bit to the role of using technology to guide the injection therapy and how and when that's used and what type of equipment is used and when?
Yeah, absolutely. So yeah, the technology, the image guidance is often critical in getting a good outcome on these treatments. That big piece of equipment that you saw in that photo of me was our fluoroscope. And the fluoroscope is an X-ray machine that lets you get real-time images while you're doing a procedure, which is critical for safety because some of these injections, you're doing injections at the spine or certain parts of the joints, they're pretty close to significant neurovascular structures that you don't want to be putting a needle into or don't want to be injecting stuff into. So we use the X-ray to confirm needle placement, and then we use contrast medium, which is a fluid that shows up under the X-ray. So you can push some of that fluid, and that's benign, doesn't have any issues if you inject it into like an artery, for example. But that artery would then light up on the X-ray, so you would know that your needle placement is off and you need to adjust it. The contrast also will highlight the joint capsule or joint spaces, so you can confirm that the fluid that you're injecting is going to go where it needs to be. So X-ray or fluoroscopic guidance, use it all the time for the spine injections. Gives you a very, very good idea that you're injecting the right spots and you're doing it safely. Ultrasound is another very useful tool clinically for doing these injections, because in the hands of a skilled sonographer, you can use that machine to not only help you localize your injection to make sure it's in the right spot or you're hitting the right structure, but you can use it all diagnostically. For rotator cuff pathology, for example, I believe ultrasound is about 97% specific for diagnosing supraspinatus tears, and it's about half the cost for the patient, maybe even a little less, than doing an MRI, which is the gold standard for that. So ultrasound is a super valuable tool. I use it pretty frequently for soft tissue injuries, things that aren't as deep, like tennis elbow. You can view the lateral condyles and the extensor groove tendons really well on that. There's certain types of perineural injections you can do with deep nerves when you use ultrasound to identify that. One common thing is for carpal tunnel. You can do a median nerve release by visualizing that carpal tunnel with the ultrasound probe, and then being able to place that perineural solution right on the nerve.
Thank you so much. There have been a couple questions regarding using cord blood, Wharton's jelly, any other types of stem cell sources. And so could you speak to the selection of that, and as well as some of the training? I know that there have been a few mentions of, what is the training? And I know you talked about the honors track at SCNM, but maybe if you could talk a little bit about, the stem cell sources and the training, that would be fabulous.
Mm-hmm. So the work with allogenic stem cells is pretty promising. There's been our namesake of the clinic, Dr. Neil Riordan, has a center in Panama where he treats a variety of conditions with umbilical cord cells. There are some issues with using allogenic cells, particularly in the United States, because the doses that you see in some of the research from studies out of Europe and other places are really high. Doses in the range of like 20 million cells a day for multiple days in treatment, administered IV, for example. In the United States, none of the companies that produce allogenic stem cells can hit those numbers reliably, because it requires culturing the cells, which is something that's not permitted by FDA regulations right now for those outfits producing stem cell products. We do have some stem cell allografts from amniotic tissue or umbilical cord, which we have used and had some interesting results, some promising results. But because the stem cell counts are a little lower than what you see in some of the papers, we found that using them to supplement or augment an autologous stem cell procedure is often the way we go. Folks who we draw bone marrow tissue, which also doesn't have a super high stem cell count when you use small volumes like 60 cc's or so. Combining that with a dose of an allograft seems to increase the activity of the cells in both the allograft cells and the autologous cells, especially for our older patients. So, yeah, we have looked into using allograft tissues, and they are pretty promising. The other part of that question, Joan?
Was just in regards to the training that that happens in school that's helpful to prepare people. And I know you can speak to SCNM. I can talk in more general terms after you're done.
Okay. So the training, at SCNM, during your clinical rotations here, you have the option to rotate through shifts at the Neil Riordan Center, where you'll learn a lot of the basics. I mean, I think most of the training, the really critical part of being trained to do regenerative medicine well, is a good understanding of orthopedics, particularly in our case. Well, all the regenerative applications we treat here at the center are musculoskeletal complaints and pain. So a good understanding of both your neuroanatomy and your pain, knowing how your nervous system processes pain, as well as the orthopedics of understanding the mechanisms of joint injury, knowing the anatomy, that really dictates your techniques of how you inject. So students get really well versed in that during their time here. The honors track students, of course, get a little extra focus on the literature, on reading the clinical trials, on understanding the developments in this field, because it is moving so fast, and it can be tough to keep up with that. So our journal clubs and part of the honors track is helping those students navigate the literature and do that. SCNM has also offered workshops, injection workshops for folks who maybe are practicing NDs that want to learn more and get some hands-on experience in doing injections with some supervision of some docs here at the clinic that do that. We hold those probably about once a year at SCNM, so that is an option for training for folks that want to get more. And our residency programs are really where kind of the meat and potatoes of this training happens, because these residents have the we have the resources to really spend a lot of time with these docs after they graduate and train them in the hands-on ins and outs of doing these procedures. So residency is probably the biggest place where that happens.
Dr. Seenauth, for NDs who have already graduated, or conventional doctors for that matter, can you recommend some resources for docs out in the field who maybe wouldn't qualify for a residency at this point, but do want to incorporate this into their practice and learn more?
Okay, so yeah, the injection workshops that SCNM holds are a good place to start. Really, we cover most of the injection techniques and approaches for treating extremities. So things like knees for arthritis, shoulders for rotator cuff pathology, tense elbow, things like that. And our workshops are usually like a 2-day hands-on workshop, pretty small, small scale, so good, probably 2 or 3 students per faculty member. So you get a lot of guidance and direction. You get to practice doing those injections on real people. So that does a lot to help you build your confidence that this might be a tool that you could use in your practice. There are some large groups around the country, not necessarily led by naturopaths though, that hold trainings. I believe the American Association for Orthopedic Medicine does some trainings a couple times a year. They have a big annual convention, which so looking into something like that might be a good place to start as well.
Thank you so much. There was a question just in regards to the case report. Jamie, if you could put up the case report again with the PubMed reference. Mm-hmm. Thank you. There you go. Perfect.
No, that's actually back a couple more slides.
Yeah.
Sorry, it's the first case, the second case, this one.
Thanks, Jamie. So there is a question about exosome therapy. In addition, can you comment on that?
Exosome therapy is something that I've been curiously following, not something that I've gotten into using. Exosomes are a really interesting thing, and we know that this is part of how stem cells communicate with the tissue around them. When you put them into an environment, they package up mRNA or other signaling proteins into these vesicles that can be sent out and received by other cells. So the target cell, the recipient, can then pick up this exosome and then take that mRNA and immediately start transcribing for proteins without having to go through the whole DNA synthesis part of it. So it's like a shortcut to some kind of outcome these stem cells can do, which is super exciting. The drawback to it is that we don't know exactly what causes the stem cells to produce exosomes or decide what stuff to put into the exosomes. So there are companies out there that are selling exosome products. So basically they culture the stem cells and then they collect whatever exosomes they produce and then just package that up and say that these exosomes are going to heal you. But the work, I don't think the work has really done the deep dive into figuring out how do we know what types of effects those exosomes are going to have. There's been some good clinical outcome data on that. People are getting responses, but at this point, I'm not 100% certain that we can predict how the exosomes are gonna work when we use them clinically. So I haven't gotten into that yet. but it's still something that I'm watching very closely.
Oh, I just realized I was on mute and I was talking, so sorry about that.
Okay.
Dr. Seenauth, just wondering if you have any guidance on Western medicine, conventional focused institutions and their work on regenerative medicine. I don't want to put you on the spot, but just offhand, if you know if there's any research happening in conventional organizations like U of A or Stanford and Harvard, et cetera.
Yeah, I'm not personally aware or part of any of those initiatives right now. There's been a big focus on, from a policy perspective, to include things like naturopathic care in models for pain treatment, like multimodality pain clinics. Earlier this year, I worked with a group called the Integrative or IHPC. Integrative Health Policy Consortium in Washington. We were having a conversation on chronic pain, and basically all their data that was presented supports this idea that using, if not naturopaths specifically, the modalities that encompass naturopathic approach to pain management lead to better outcomes, especially when you compare to outcomes from just managing through medication. So from a policy perspective, I think the impetus is there. There have been some challenges in research of how do you quantify the effectiveness of a multimodality approach, because it's difficult to do the whole placebo-controlled randomized control trial when you have multiple interventions and difficult to blind. So that's a challenge to our research. However, there is a growing body of evidence, and you could find this on PubMed pretty easily, of papers using things like PRP, bone marrow concentrate, bone marrow-derived stem cells for arthritis, and even within the last 3 or 4 years, that's kind of blown up on. So there's varying qualities of studies, but generally they're showing very good outcomes. I think last year, for example, there's a paper on using PRP, comparing it to using hyaluronic acid injections, which has been a standard for treating knee arthritis, showing that PRP is more effective than that. So that's just one small thing, but I think we definitely need to get together and put out more research to get attention, the right kind of attention from the conventional medical community as well.
The actual PubMed reference, but we'll send that to you in a second, Dr. Waite. So if you can just hang on for a second, we'll grab that for you. So Dr. Seenauth, I really want to thank you again for taking your time out of your busy clinical schedule to come here and share a bit about some of the emerging regenerative therapies that are being offered at the naturopathic colleges. So thank you again so very much for sharing this and your time. And Jamie, would you mind putting up the contact information page real quickly? Thank you. So I really do appreciate all of your time, and those of you who've come to the webinar, and Dr. Seenauth taking the time for us today. So with that, we're going to conclude the webinar. And if you have not gotten your questions asked, or you think of any as you're leaving, please reach out to us at info@AANMC.org, and we'll be happy to connect with you at a later time. Thanks so much all for coming, and we hope to see you next month.